Good morning. Yeah, I'll try to be a little loud. Can you hear me? All right? Okay. So we're all ready to start the next session of brainstorming with the Brainstem today. How we've organized these talks is that we saw the external features, a bit of introduction yesterday, and from today we're going to spend 3 days on looking at the specifics of each part of the Brainstem. So we start with the midbrain today. Tomorrow is going to be pons, and the day after would be the medulla. And the next week we have 2 classes on the cranial nerves, and the final lecture would be on brainstem syndromes. Okay, so what we're looking at understanding today is the general structure of the midbrain. Now, we saw the external features, some of the important structures yesterday, but today we are going to look within. We're going to look at sectional anatomy of the midbrain. We're going to look at a few important long segment tracks, just a few of those. 2 cranial nerve nuclei. Yes, anybody can remind me which cranial nerves are associated with the midbrain? 3rd and 4th. So we're going to look at 2 sectional levels, one at the level of the 3rd cranial nerve, one at the level of the 4th cranial nerve. And then we're going to look at some correlation between the structure and function of some of these areas of the midbrain. Now, this is an interesting section. You're not going to be quizzed on this. You'll never see this probably in the exams. But there's a reason I've put this up. Can anyone, don't look at the labels, but can anybody identify any structures based on what we discussed yesterday from the external anatomy? The aqueduct, wonderful. So that is the most constant anatomical landmark in the midbrain. Okay, that's what you should look for. The first thing is to look for the CSF cavity. And you can see the aqueduct here. Okay, and remember from yesterday that the aqueduct is the only part of the lower segment of the CSF pathway which has brainstem both in front, anteriorly, and posteriorly around it. The 4th ventricle does not look like that. It's kind of open posteriorly, yes? So the aqueduct, that's how you identify this is a section close to the midbrain. Anything else that you can identify?
Somebody said mammillary body.
Yes, who said that? So mammillary bodies are seen in this section, but that's kept there for a different purpose. You can see the mammillary bodies, and oops. And the mammillary bodies are these structures here, okay? Not to be confused with the 2 rounded structures at the back. Those are the superior colliculi. We saw those yesterday, right, on the external surface, yes?
Areas where it's labeled for spinal or cerebral peduncles?
The cerebral peduncles are here. But this isn't a true section from the midbrain. This is a section that we're looking at which is at the junction of the diencephalon, which is the thalamus, and the midbrain. And I've put this up for a specific reason. You see, modern medicine, we have a reductionist approach to everything, to the brain. So we break it up into little sections, and then that's how we study it. But that's very good because that's the best way to study it. But I just wanted to prove a small point to you that that's not how the brain is organized. When you look at the brain, it does not say that this is the midbrain and that's the pons and that's the medulla. That's how we've classified it, yes? So there are a lot of structures, a lot of tracks which run throughout, and they don't necessarily follow our division of, breaking up the brainstem. So this section shows you, it's interesting because it shows you features of the midbrain and it shows you features of the thalamus. So if you look at this, these are the mammillary bodies. Okay, and then you have the yes, you have the geniculate nuclei, the median and lateral geniculate nuclei. You've seen that in the thalamus, and you have some other interesting structures like the pineal gland there, the pineal body. And along with that, you have structures of the mesencephalon, the midbrain. So you have the superior colliculi there, the aqueduct which was pointed out earlier, you have these two rounded structures here, which is very typical of the midbrain section. You will not see this anywhere else on the brainstem. If you see this, you know that it's midbrain. The aqueduct and these two rounded, reddish-looking rounded structures. These are called the red nuclei. Okay, we'll look at that a little bit in detail later. So this is interesting to understand that how the brain is organized. There's a lot of overlap between different levels. Now, the first section that we look at is at the level of the superior colliculus. So look at that, and you know where the section's taken, at the upper level superior colliculus. This is the definitive structure that you should be absolutely familiar with, because this is what you'll be tested with on the exams. When you see this, you know it's midbrain. Okay, you will not be shown mostly other levels. Some of the important features that I've already pointed out will start from the back, the dorsally. So these are the superior colliculi. Therefore, the structure is the section is at the level of the superior colliculus. And just below that, you have the aqueduct there in the midline, and you have this pale gray area which goes all around the aqueduct. That's a very, very important area. It's called the periaqueductal gray. Okay? We'll look at that a little bit more in detail later. Now, can anybody identify a cranial nerve here? Yes? Okay, so don't read the labels here. But that's the nerve. See, that's how it comes out. So that's the nucleus there. And you see the fibers running all the way through and through the red nucleus. They do not form synapses in the red nucleus. They have no connections with the red nucleus, but they just pass through it. Okay? And then you have some fibers which go medial to the red nucleus. Yes. And then it emerges out from the front ventrally over here. So we saw that yesterday. The third nerve emerges out medial to the cerebral peduncles. This is the cerebral peduncle here. Yeah. Now, the other important structure that I want you to see here, and you're going to remind me where you've seen this before, is the medial lemniscus. So we saw that in a review class 2 days ago. So it's part of the dorsal column medial lemniscal system. Very good. And is there anything peculiar that you notice about this? You look at where is the dorsal column, where does it end? Where are the nuclei present? If you take a section of the brainstem, which part? Is it dorsal or ventral? They're dorsal. Yes, both the nuclei, nucleus cuneatus and gracilis, are both dorsal. Now look where the medial lemniscus is. It's much more lateral. And there's a reason for that, because the tracks, they decussate. They cross over to the other side, and that's when they ascend up. Yes? And as they ascend up, they come closer and closer to the corticospinal tract, which is here. And they come really close to it as they go higher. And then it goes through the internal capsule, thalamus, and the sensory cortex. Yes. So that's the reason they're coming closer to the front. Okay. So that's an important landmark, the medial lemniscus. And then you have the red nucleus. We already spoke about that. This is the area of the corticospinal tract, this big, bulky, anterior part of the cerebral peduncle. Now, between the crus cerebri, that's what it's called, and the red nucleus and this region here, which is called the tegmentum, there's a band of darkly stained cells there. This is called the substantia nigra, and this forms a part of the basal ganglia. We'll look at some of the details of that later. Now, yeah, I know. Yes. It doesn't work here very well. Can you hear me? Better? Yeah, okay. All right. So I found this on the net. This is a very interesting way to remember the midbrain. Okay? Now, this works with any kind of a bear face. I've used a panda. You could use the North American grizzly. It doesn't matter. But it's very interesting how you can remember the structure, how it looks. Yes? You have, it's an inverted phase. The cerebral aqueduct forms the mouth right there. And the red nucleus and the medial lemniscus would form the eyes. And the crus cerebri would be the ears. So although it's not perfectly fitting there, but you get the idea. And you know, it's easy to remember it if you do things like this. Now, this is what I was telling you. This is the most important section for you to remember. This is a diagrammatic representation. This one, with this one on the right, will probably, you won't be seeing this in the exam, all right? But I've put it up for a reason. Now, this is a section, the one on the left is a section through the superior colliculi, okay? You have the third nerve nucleus there. The third nerve fascicles which pass through the red nucleus and come out here, okay, and the medial lemniscus. So you can see all these structures here. And although the basic shape remains the same, the structure basically remains the same, there are very important differences. So if you look at the inferior collicular level here, okay, you see that the third nerve disappears, the red nucleus disappears. So there's no red nucleus lower down in the midbrain. It's only in the upper part, okay? And then instead of the third nerve, you have the fourth cranial nerve, the trochlear nucleus here. And I told you it's a very peculiar cranial nerve because of what it does. It travels all the way around the brainstem and then exits and goes to the opposite side. It decussates. And then it innervates a muscle on in the opposite eye, okay? Now, if you look at the position of the third cranial nerve and the fourth cranial nerve, they're more or less similar. So if you look at a vertical distribution, you'd have third, fourth, and sixth more or less in the same column. And that's important because of all the connections that these three nuclei have with each other, and they're used for conjugate gaze. We'll look at that a little bit later in one of the classes on cranial nerves, okay? But it's important to just identify these few structures which are missing here. Now, how I wanted to organize the talks on the sectional anatomy would be to look at it this way. You have the basic division. I told you yesterday what the tectum means. Tectum comes from the word roof. It's Latin, and roof with reference to the CSF space. So it's dorsal to the aqueduct, and therefore it's called tectum. That's where the colliculi are located. And then you have the part which is in front, which is called the peduncle. Now, the peduncle is technically divided into two parts. The base, that's where you have the corticospinal tract here, and the inner bulkier section here, that's called the tegmentum. Now, this division, again, is an artificial division. We do it just to understand the brainstem a little bit more in detail. So it's good to break it up like this, and then you have each area, the tectum, the tegmentum, and the base, having both gray nuclei, gray matter, and white tracks that go through. Now, some of these I've circled. We'll look at some of these areas in a little bit more detail. The ones that are ticked are something that we have already seen yesterday. So we saw the aqueduct, we saw the colliculi, we saw the brachium, yes, and the interpeduncular fossa. Now we'll look at some of these in a little bit more, in some more detail. We begin with the tectum, the uppermost part, dorsalmost part of the midbrain. Now, the tectum, you know, is made of the colliculi, so two superior colliculi, two inferior colliculi. And I don't know why it keeps doing that. We also have the periaqueductal gray, which I mentioned earlier. Now, this forms part of the tectum. It also forms a big part of the tegmentum. So I've left it for the tegmentum. We'll look at it later. Now, in the tectum, you have the superior colliculi, which we have seen yesterday, but it has an important tract that runs from the colliculi down to the spinal cord. Now, the colliculi, superior colliculus, you know, is associated with the visual system, yes? Now, why would you have a tract running from the visual system down to the spinal cord? Any ideas? Sorry. For what? You say proprioception? Yes, that's correct. So you need to understand that every time that you move the head, the eyes and the visual field needs to readjust itself. Okay, you need to have these fine movements, even in a little bit. If you move your head a little bit, there's always constant adjusting happening. And that's how you can see the three-dimensional space as a constant image, right? Otherwise, you would not be able to get this image of reality. It would be quite different. Now, to do that, you need constant little micro adjustments that keep happening repeatedly. And therefore, you need the tectospinal tract. Tecto because it comes from the tectum, goes down to the spinal cord. So tectospinal. You need not remember exactly how this tract runs. Yeah. It also decussates, and it also has connections with the contralateral cranial nerve nuclei 3, 4, and 6, which you would expect because they are the ones that control the eye movements. Okay. And it ends in the spinal cord, so we won't go into the details of where it ends. Now, why would you need a spinotectal tract? This runs in the opposite direction. Because that's the one that's going to give you the information about the proprioception. So it's a continuous feedback mechanism. So it's not just one movement, but it constantly adjusts the movement with response to visual stimuli. So that's why you need to have it running in both directions. Okay. Now it's exactly the opposite. It runs up and ends in the superior colliculus, and then it's got connections with the cerebral cortex. Now you've had a class, I think, on visual. Dr. Ulal's taken that, right? So you are already familiar with this, but I thought it would be a good idea to just revise this a little bit. And just anterior to the tectum is a pretectal area, okay? And that subserves or helps in the light reflex. Now what happens is from the retina, when the optic nerve is carrying the information from the retina, most of it goes into the lateral geniculate body, but some fibers end in the pretectal area of the brainstem right here. The synapse there, and then you have the fibers going in both directions to both sides of the Edinger-Westphal nucleus, and that is one of the reasons why you have the direct and the indirect light reflex, or the consensual light reflex. And then that is carried by, it starts from the Edinger-Westphal nucleus, and those are the preganglionic parasympathetic fibers, which are carried by the third nerve up to the ciliary ganglion, and then you have the short ciliary nerves, which innervate the pupillary constrictor muscles of the iris, and that causes constriction. Yes. So this is also very close to the tectal region of the midbrain, and that's why I've put it up there. So if you know that much about the tectum, that's sufficient. You need the colliculi, the tectospinal tract, spinotectal tract, and the pretectal nuclei. That's enough. But we now come to the tegmentum. Now, tegmentum is the area which is anterior or ventral to the aqueduct. So this region here. Okay? We leave out the base, the basal part, the crus cerebri, for later. Now, the important structures that you're seeing here are the red nucleus, the tracts of the red nucleus, the midbrain reticular formation. We spoke a little bit about that yesterday. A very important aspect called the ventral tegmental tract and the substantia nigra. So if you know these 4 or 5 structures here, that's enough for the tegmentum. You need not know any more details about it. So we look at some of this in a bit more detail. The red nucleus is a part of the motor system, yes, but not part of the corticospinal tract. So the motor system basically has two ways that it controls the muscles. You have the corticospinal tract, which is the straightforward control of the muscles, right? But then you have these so many other tracts which do the fine tuning and have additional functions, because motor functions are very complex. You need this additional support to fine tune certain things. Now the red nucleus specifically innervates muscles of the upper limb and the flexors. Now, if you look at comparative embryology, comparative anatomy with the lower animals, it plays a very, very important role in some of the lower vertebrates, not so much in humans. So some people consider it as vestigial or redundant in humans, but it also has a role, a very important role when a child is crawling, for example, when the corticospinal tract is not yet myelinated. The myelination gets completed by first year of life. So by that time, the corticospinal tract is more rudimentary, not working so well. And that's when the rubrospinal tract helps a lot. So the crawling mechanism that the child does, it uses its arms a lot, and that is subserved by the red nucleus. Also, in the adult, we see a little bit residue of that is when you walk or when you examine gait in a patient. You see that there's something called automatic associated movements of the gait. So when you walk, you move your hands, right? Now this doesn't happen, it's not a voluntary thing, it's an involuntary thing. And that kind of an action is also ascribed to the red nucleus. An important aspect of this is when we have a condition where the patient is comatose, okay? Very briefly, I'll mention this to you. It's a condition called decorticate, a condition which is called decortication. A decorticate posturing, rather. So what that means, the word tells you itself that the corticospinal tract or the cortex is, just remember it that way, that is no longer functioning to control the motor movements. And the person's working on a reflex mechanism. Now the reflex is happening from the red nucleus, and therefore in decorticate posturing, you see the flexion movement. When you give pain, you see flexion of the upper limbs and extension of the lower limbs. You don't see a flexion of the lower limbs because the red nucleus, rubrospinal tract, does not reach the lower part of the spinal cord. It ends at the upper thoracic level. Okay? Again, you don't need to know the exact pathway. Yep. It can also happen spontaneously, but usually in a patient like that, the arms would be extended, and when you give them a little stimulus, the stimulus is important. For some people, it could be a loud clap, a noise, a pain sensation, a sternal rub, something like that, or even light sometimes. If you shine a bright light on the eyes, that could be enough to stimulate the reflex. Now, this is an important area of the midbrain. So it's called the ventral tegmental area. Yes, it's not a very specific or a very well-organized tract, but it's got a lot of interesting connections. Now, if there's a ventral tract, there's a dorsal tract as well. The dorsal is less well-defined, so I wouldn't, we shouldn't bother remembering too much about that. But just remember the ventral tegmental area. It's in the anterior tegmental part, the ventral part of the tegmental, and it is a dopaminergic pathway. So it has dopamine as its main, it's part of the monoaminergic pathways of the brainstem. That means it uses dopamine as its main neurotransmitter. And there are two such pathways. So we have the basal ganglia pathway, which is important in diseases like Parkinson's disease. Okay, that also uses dopamine, but that's purely motor. What we're talking here is something different completely. This also uses dopamine, and it's associated with pleasure and addiction. Okay, it's a complex pathway, and if you can see that some of the connections are shown here. From the brainstem, it connects to the limbic system and to the frontal cortex and the prefrontal region here. So these are important structures. Now, when you think of the brainstem, usually you wouldn't think about these kind of functions happening there. But this is a very important aspect of the brainstem because it deals with addiction, and it has important implications, obviously, in certain neuropsychiatric disorders. Okay. Yeah. Yes. So that's just to show the two dopaminergic pathways. I don't think they have too much in connection with each other. They're two different pathways. Yeah, but both of them have dopamine as the main neurotransmitter. That's why. Okay. Now, you've also had a class on pain, right? Pain has been completed, yeah. So you know that the pain is an important sensory modality. And the pain has an ascending tract, and there are a couple of pain tracts. Now, does the pain mechanism in a body, in a person, have descending tracks? Or do you think there's something like that? Is there something that's needed to modulate the pain mechanism? Yeah. Now, the periaqueductal gray does exactly that. It modulates the pain response of a person, and it forms a part of the enkephalin and endorphin mechanism. Okay. Now, what this does basically is it reduces the perception of pain by releasing natural painkillers like opioids, which exist, which occur in the body. This is very important in recent advances in neurosurgery, because we have a surgery which is called deep brain stimulation. I think some of you would be familiar with that. That's when you implant electrodes deep within the brain to subserve a specific function. It was first described for Parkinson's, and it's also being used a lot in periaqueductal gray stimulation, and this is a recent paper for that, from that. It's a review article. And what they do is basically put in electrodes to that region to stimulate this area so that there is decreased pain perception. Now, why would you want to have this? Because this is done in people who have intractable pain syndromes, neuropathic pain syndromes, central pain syndromes. These are all almost synonymous terms. So pain is usually, we consider it as a peripheral symptom, yes, but you can have pain occurring within the nervous system as well. And there are many reasons for that. Tumors can cause that. There's so many other reasons. We won't get into that. But central pain is terrible because it's very diffuse, a very dysesthetic kind of pain. It cannot be localized, and our regular pain medications don't work very well on that. So this particular surgery has been modified for people like that. And they go in, put electrodes in the periaqueductal gray and stimulate that area. And that is connected to a battery which lies in a little subcutaneous pocket on the chest. Okay, and you've got electrodes going from there right up to the electrodes which are implanted. You have wires going from here to the electrodes which are implanted. And you can switch the battery on and off. Like if you want to, person sleeping at night, you want to save battery time, you switch it off. And that's done by a magnetic switch, which you can place on the battery. So it's a very interesting concept. And it works very well. It's been around for about 25, 30 years now. The midbrain reticular formation, again, an extremely complex area. We don't get into the nitty-gritties of this, but just to remember that it's there in the tegmentum that you can see here, right? It's spread in the tegmentum around the red nucleus area. And basically, there are two parts to it. You have the ascendic reticular activating system, which is associated with consciousness or conscious experience. And finally, we come to the basis pedunculi, or the crus cerebri. Okay. Now, this part again is part of the anterior or the ventralmost part of the peduncle, and it consists mainly of corticospinal tract and corticobulbar tracts. Now, corticobulbar tracts is part of the corticospinal tract, which ends on the cranial nerve nuclei to subserve certain functions. We'll discuss that in the cranial nerves. Now, they have a certain arrangement. I don't know if this is important. I don't think this is very important for you, but there's a topological arrangement. Just like in the internal capsule, you have one part, the posterior limb, which has the motor fibers, and then you have the sensory fibers, and then you have the genu, which has the corticobulbar fibers, corticonuclear fibers. So just like that. And there's a little mnemonic I wanted to share with you. I don't know if it's important, but since it's one of the major motor tracts in the body, you remember the word fatal, because if that's not working, it's quite fatal to the patient, right? So F, A, T, and L. So face, arm, trunk, and the leg. And those are arranged in different ways. So even in the spinal cord, in the internal capsule. But that's just in passing. I'm not sure if that's really required for you. I'm sorry. And we have, so the substantia nigra, that's the last bit right here. This is the region which is the border area between the tegmentum and the basis. Now, that separates the corticospinal tract from the rest of the tegmentum. Now, why it's called Nigra? Because of its dark staining. In initial histological studies that they did, it stained black in color, and therefore the word Nigra is there. It plays a very important role in Parkinsonism, and I think that will be covered by Dr. Ulal with the basal ganglia lectures. But what's important to understand here is that this is, again, a dopamine-based system, and there is a decrease in the dopamine-secreting neurons, and that's the basic pathology in Parkinson's disease. So Parkinson's disease has three basic symptoms. You have tremors, which are, tremors at rest. If you remember, you relax in the park. So Parkinson's has rest tremors. There are different kinds of tremors. You need not know this, but you have this kind of pill rolling tremors. And then when the patient starts to do an action, the tremors decrease. So they're rest tremors. And then you have akinesia or hypokinesia, very slow movements. They're very, very slow in whatever they do. Bradykinesia is a term which is used for that. Okay? And then there is a certain rigidity in the body. Okay? These are the three basic symptoms of Parkinson's disease. Now, I'm going to show you a little animation of a video on what a deep brain stimulation surgery looks like. But you have to understand that the best effects of deep brain stimulation is on the tremors, not so much on the bradykinesia, not so much on the rigidity. Yeah. So we just look at this. It's about a minute or so long. That's the way the electrodes get in. And it's a surgery that's performed under local anesthesia. So the patient is awake throughout the surgery. It takes about 10 hours or 12 hours to do this. I didn't put up a video of a real patient with this, but if you were to see what happens to a patient before switching on the battery and after, it's like a miracle. All the tremors just stop suddenly. So it's quite remarkable. What's important to understand in these kind of cutting-edge technologies that this patient selection is very important. You cannot expect all patients to benefit from this. Therefore, you saw that it's 70 to 80% of patients who can get good relief of their symptoms, because Parkinson's is a complex disease which involves many aspects. So these are just additional slides that I put up, and we'll stop there. Yeah. Okay, so I think we finished much ahead of time today. Any questions? Yes. Yes. So,
The reason why Dr. Dadlani did not go into details is because we don't require that. But
So you stated that the ventral tegmental area is the part of the midbrain that has the dopaminergic cell bodies,
yes,
and it relays to ventral aspects of the brain,
into the limbic system and also into the forebrain, the frontal part of the brain.
So the video that you just showed us, was that supplementing?
This is for Parkinson's disease. So,
well, isn't Parkinson's a lack of dopamine
in many
ratio?
areas of the basal ganglia, but specifically the electrodes are implanted in a region called the subthalamic nucleus. So there are many nuclei in the basal ganglia, and there's a complex connection. I won't get into the details of that. Dr. Ulal will be talking about that in the basal ganglia class. But so the tremors, so you have a couple of surgeries that can be done for Parkinson's disease, right? The older ones are called lesioning surgeries, where you put in an electrode and you burn a certain area of the basal ganglia. And the way you do that is by radio frequency. It's a little bit of heat that's put in there, that area burns out, and you get relief of the symptoms. Now that is done in certain areas, nuclei of the thalamus, to reduce tremors. But it's not so effective. And it also causes problems in other regions. So they came up with this. Now this, the electrodes get into a nucleus called the subthalamic nucleus, which is below the thalamus, and that's where they're implanted on either side. And the procedure is quite tedious. It's very long. It's very uncomfortable for the patient, so I stopped doing it. I don't do it anymore. But it's like 10 or 12 hours, and you have a neurophysiologist, you have a neurologist, and the surgeon, and everybody's in the operation theater for 10 or 12 hours. And the way it works is you put in a little electrode which records the electrical signals from the brain. Okay, so that's the first step. And you start going in millimetrically, 0.5 millimeter at a time. And you record the signals. And the signals are very specific for each area of the brain. So when you enter the thalamus, for example, it sounds like rain on a tin roof. That's the sound you get. And you hear this large crackling sounds. So you know you're in the thalamus. And then you go beyond that, the signals come down, and then you know you've passed the thalamus, and then you know you're getting into the subthalamic area. Okay, there's special softwares now which can help guide the surgeon in which direction to go. But basically that's how it works. And then you get a certain signal from the subthalamic area, and you know that's where you stop. So you get the recording electrode out, and you put in a stimulating electrode. And that's how it's done. Yeah.
What Dr. Dadlani said, if correct me if I'm wrong,
Yes.
is basically he's talking about different ways of treating Parkinson's tremors. Now, the one that he talked about earlier is substantia nigra. Now, he mentioned the one that he talked about now is subthalamic nucleus, and we have still not talked about subthalamic nucleus. I will talk about that when I get to basal ganglia circuitries. There are various ways, right?
Yes.
So, and what he said was basically more easy method is going to substantia nigra, because you're not going through other areas, you're much more easy compared to subthalamic nucleus. Now, I think Pasha has the question. His question was,
For the ventral tegmentum.
yeah, ventral tegmentum. That's why I put
Now,
up that slide.
Yeah, I'm sorry.
That's the reason I put up that slide.
Ventral tegmental area, we are not concerned with deep brain stimulation. So deep brain stimulation is happening in the periaqueductal gray and the subthalamic areas, not in the ventral tegmental. Ventral tegmental area is a very diffuse area, so you really can't do things like that, putting in electrodes and stimulating certain areas, because it's very diffuse. It's kind of like the reticular activating system. Yeah, so it won't work so much there. Yes, yes. So, yeah.
The tegmentum, it will relate to the substantia nigra, which is located in the base, correct? Because the
ventral tegmental area and the substantia nigra both are dopaminergic systems. But what I want you to understand here, there may be some connections there, but they are basically subserving to separate functions. So the substantia nigra is part of the basal ganglia, which subserves the extrapyramidal system, and the ventral tegmental area also dopaminergic, but which subserves things like pleasure, addiction, and things like that. So it's completely different. It's two different things we're talking about.
Okay, I think the confusion that's coming here is quite legitimate. I know,
Yeah.
I'm sure you also appreciate that. Tegmentum, like he said, Dr. Dadlani said, is the floor of the up towards the ventral side of the aqueduct. The entire thing is called tegmentum. Now, within that, we have a designated area called ventral tegmental area. It's very confusing. I don't know why they came up with these terminologies. Tegmentum is ventral. Now, within the tegmentum, we've got a designated area called ventral tegmentum, and that, also called VTA, is associated with dopamine, which is associated with pleasure. So, for example, if you have to stimulate the ventral tegmental area through the limbic system, it makes you feel happy. It makes you seek activity that you've been doing before. That's also dopaminergic. But when he said tegmentum, that is dopaminergic for Parkinson's.
I'm sorry, I should have clarified
no,
that. So tegmentum is different from ventral tegmental area, which is a small part of the tegmentum. Yes.
Okay. I know Dr. Dadlani will not feel, because he has been with me for a long time, so he doesn't mind my interrupting, and we are working
absolutely,
together.
no
Okay? Absolutely. Don't feel I'm trying to. It's
No problem.
Okay.
Questions?
Love these discussions. I wanted this because Brainstem is a nightmare, but it should not be.
So for the trochlear nuclei, like
Yes.
the nerve after it goes through the nuclei, it decustates and crosses back over,
Right.
correct?
Yes.
Does that mean that the right side of the brain would control the right superior oblique muscle, the eye? Because does it cross over to the nucleus and then it crosses back over?
Yes, but you see, the trochlear nucleus or the trochlear nerve does not have very significant supranuclear control in that sense. So it's not like some of the other nuclei, like the facial nucleus or the hypoglossal. We look at that. It does not work so well with the trochlear nucleus. It does have, of course, supranuclear control. Every cranial nerve has that, but it's not very specific. So you cannot have a lesion there which has supranuclear control and then affects the contralateral trochlear nerve and then the ipsilateral superior oblique, if that's what you're saying. Yeah, it doesn't work that way for the trochlear nerve. Okay, the control is more diffuse and the extraocular movements of the eyes are much more complex. But if you look at the hypoglossal nerve, which controls the movements of the tongue, that is very specific. So when we do that, I'll show you how you can have an upper motor neuron lesion in the hypoglossal, which is very different from a lower motor neuron lesion. But that doesn't work so well with the trochlea. So basically, there is control like that, but it's not clinically so relevant.
Good. In fact, like you, Dr. Dadlani said, for example, hypoglossal and facial, we say upper motor, lower motor. But when it comes to eye movement, we don't use that because the centers for eye movement are quite diffuse. It involves the superior colliculus, it involves the frontal eye field. It's very, very diffuse. That's why we don't have that type of a categorization. However, if the trochlear nerve is paralyzed,
Yes.
of course, it's already come that side. So it's going to be on the ipsilateral side, right? Yeah.
And many of these cranial nerves, it's interesting to see that they can be injured within the brainstem if there's a problem there, but the trochlea isn't one of them. So you can't have a stroke which affects part of the fascicles of the trochlear nerve, but it's not very common. So like the third nerve, you'd see the third nerve being involved when we do brainstem syndromes. You'll see the third nerve being involved more often than the trochlear nerve. So it's peculiar in many, many ways, and I don't think we completely understand why it decussates and why that kind of control is there. It's a little different. I mean, I've thought about this many times, but we were having that talk yesterday. It's confusing. I'm not sure why the nature has arranged it quite like that. Yeah, if it serves a special reason or special function, I'm not sure.
Sorry to keep asking questions.
No, that's
so the tectospinal and the spinal tectal tract. So
Yes.
the tectospinal, the ocular motor neurons
Yes.
activate, and then they have a tectospinal downward tract.
Yeah.
And then there's the spinal tectal tract.
Yes.
Is that just the dorsal column medial lemniscus tract? If it's proprioception that's being relayed back up?
No. Because this is a separate tract. It can have some connections with that, and proprioception and movement is quite complex. So you have the dorsal lemniscus system. That's one. The tectospinal, spinotectal. You also have, we will look at that a little later, the vestibular connections. That's probably coming in tomorrow in the pons. And so you have multiple mechanisms for the proprioception. So, when you rotate your head or you turn your head this way, your semicircular canals in the ear are doing something which tells you that everything's not all right. But how do you maintain your visual field and understanding that the world is this way, and the world doesn't rotate with your head position? So that is the vestibular spinal tract. Okay, so there are multiple mechanisms. So the ones that happen with the vision are different from the ones that have with the vestibular, and you do have feedback mechanisms between all these because you don't want them to relay different information. So they need to talk to each other, right? But they are different mechanisms. So the dorsal lemniscus system is different from the tectospinal, spinotectal, and the vestibular spinal system.
So they're both relaying similar information. It's just being modulated differently.
Yes, but with different stimuli. The dorsal lemniscal system is a proprioception of the limbs. Okay, so when I do this, I know where my arm is based on the dorsal medial lemniscal system, right? But it's not so much with vision. So when you move your head and still try to maintain the world in a three-dimensional proprioceptive space, that happens with the with these fibers, with these tectospinal. Okay, and with the ear movement, because of the balance mechanism, that goes with the vestibulospinal. So you need all these working together at the same time. Yeah? But they're different mechanisms.
Yeah, and coming to that point again, tectospinal is not conscious proprioception. It
Yes.
does not go to the thalamus. Vestibulospinal is not conscious proprioception. It does not go to the thalamus unless, of course, there is. That's why I said, remember when talking to vestibular system, I said, you are aware of vestibular system only when there's a problem. Okay, now you feel dizzy and all that. But otherwise, most of these function at the subconscious level. So tectospinal, you call it proprioception, but it's not conscious proprioception.
Yes.
Spinocerebellar, when I get to cerebellum, I'll talk about that, is also, in a way, it's kinesthetic, but it is not, you're not aware of it. It's unconscious kinesthetic. So tectospinal is also the same way. It does not go to thalamus, but it functions subthalamic level. So don't confuse, they don't go together. They might be running parallel at some point, but they don't go, both of them don't do the same thing. Okay?
Yeah, that's a very, very important point to understand, that you have two types of proprioception systems, yes.
Fantastic. I like it this way. Right? Okay. So if you have no more questions, go back, settle down on your books. All right? Thank you.
Yeah. All right, thank you.